Alrighty, welcome everybody to the daily EKG review. My name is Reed. If you enjoy this content, feel free to like, comment, or subscribe, and leave me any feedback. Love to know ways to get better. So we'll start off by doing what I always love to do with EKGs, and what I like to say is take a look at the forest and look at the trees, and the trees are QRS complexes. And so I look down here at our lead strip or our rhythm strip in lead 2. You see I've got a narrow complex QRS. It's regular. It appears to be quite rapid. If I start, here's one that falls in a solid line. So 300, 150. This is maybe 140 beats per minute. So we know we have a tachycardia. We know that it's a narrow complex QRS. So that tells me that it's likely coming from the AV node or higher. So I'm just narrowing my differential diagnosis down. So it's coming from the AV node or higher, and it's 140 beats per minute. Okay, so what's the atria doing? I'm going to look over at lead 1, and we'll see that P waves are kind of flat, maybe isoelectric. Let's look at our inferior leads. There are 2, 3, and AVF and see what we get. And we can see in the inferior leads, we have these P waves here. You can see these P waves in lead 2. We've got P waves in lead 3. We've got P waves in AVF. They're all negative. They're negative P waves in the inferior leads. Well, what does that tell me? The inferior leads are registering any electrical activity coming towards them in a positive fashion. So any electrical activity going away from them must mean that this P wave axis, these P waves are headed from low to high. And that is not something that we see. We don't see this in sinus P waves, because we know the sinus node is in the upper right part of the heart, and so when it depolarizes the atria, it's going to create a P wave deflection that is going to go down into the left. Down into the left would be upright in lead 1 and upright in AVF, but we're seeing the opposite, where we're seeing these negative deflections down here. So this is coming from, these P waves are not coming from the sinus node, they're coming from somewhere ectopic in the atria. And so if I look at go back to my rhythm strip here in lead 2, I can see that these P waves are the same every single time. The morphology doesn't change. So what that means is that every single P wave is coming from the same location. Same location. So off the bat, I know that there's an ectopic location in the atria that is driving the P waves, not the sinus node. We've got a tachycardia. So I'll go ahead and say that this is an ectopic atrial tachycardia. But we're not done. That doesn't mean that we can't evaluate our AV node through our PR intervals. We can see we have normal PR intervals that are less than 200 milliseconds, or 5 small boxes. And those PR intervals are the same throughout every beat to beat, so we don't have any blocks of our AV node. The AV node is then going to pass that signal on down to the ventricles in the form of a QRS. Like we said, we've got a narrow QRS, so there's no blocks. That means that our His-Purkinje system is working well. The bundle branches are working well. Our QRSs are upright in lead 1. They are upright in AVF, which tells me that the QRS axis is down to the left. So that is a normal axis. We've got good R wave progression throughout the precordium. And our ST and T waves look great, and I don't see any pathological Q waves. So what is this? This is ectopic atrial tachycardia. There is some ectopic focus in the atria that is firing off at a rate of 140 beats per minute. This person would do really well with an EP study by the electrophysiologist, and we can ablate this ectopic focus so this person can move on and not have to deal with these. So hope that helps. Have a great day.